To all of you. Last class, part 1, we have seen a case, girl 18-year-old with a severe anemia from childhood, repeated transfusions and few admissions were characteristic. She came to us with a severe backache, fever, rigor chills, and the patient had mitral stenosis. We have seen the condition producing mid-diastolic murmur. Then we went through the analysis. We found it was a hyperproliferative anemia with reticulocyte production index more than 2.5. We consider the DD of reticulocyte production index high, that is hemolytic anemia, bleeding, erythropoietin administration, and administration of hematinics. There are no hematinics, no erythropoietin, and we logically eliminated hemorrhage, and we are left with the situation of most possible diagnosis will be hemolytic anemia. And because there is a rapid reduction in the hemoglobin with the backache, fever, rigor chills, the diagnosis, the background of a long hemolysis, long anemia, long-standing anemia, a chronic hemolysis with hemolytic crisis was diagnosed. So from anemia, we have reached the possible cause of anemia in this case is hemolysis. Now, today we will analyze how to go about if you get a picture suggestive of hemolysis. So, how to analyze hemolysis? Clinical approach. Some of the histories are very important. Am I audible? Clear? Audible and clear?
Yes.
Okay. Okay, thank you. Onset is very important. Abrupt hemolysis can occur in few conditions. Classically, in some enzymopathy, particularly what? Any student? Sambhavi is always interactive. G6PD deficiency, it can come to with an abrupt onset of hemolysis. Very good, very good. She already answered. Also in hemolytic crisis of sickle cell, that also is possible. And long duration from childhood, it should tell you that you are dealing with a congenital problem producing hemolytic anemia. Childhood onset and long duration can really be genetic. So consider genetic conditions. Fatigue, it is non-specific, doesn't tell you anything about the diagnosis, but still we should know about it because it will tell the extent of degree of anemia. Past history of jaundice is very important. Recurrent jaundice is a feature of many hemolytic anemias. Recurrent episodes of jaundice with colored urine, with no colored urine and colored urine. No colored urine is characteristic of echoluric jaundice. The term echoluric jaundice standing for no coliuresis. And it indicates absence of bile pigment. Therefore, it is unconjugated hyperbilirubinemia. And there can be recurrent abdominal pain and jaundice. Can you think of some conditions? Recurrent abdominal pain with jaundice? Somebody comes with a recurrent abdominal pain and jaundice. Yes, but very good. One is sickle cell. Other condition you should think of in an elderly man, abdominal pain, jaundice, hemolysis. One condition called paroxysmal nocturnal hemoglobinuria. Paroxysmal nocturnal hemoglobinuria, a diagnosis which is often missed. Therefore, somebody comes with abdominal pain and there is evidence of hemolysis, always consider the possibility apart from sickle cell. Gallstones, Patient with a chronic hemolysis like thalassemia, spherocytosis, sickle cell, they come to you with a gallstone, and gallstone can produce obstructive jaundice. Therefore, these people who are likely to get always recurrent unconjugated hyperbilirubinemia, they can develop obstructive jaundice, which now will be conjugated hyperbilirubinemia. That is due to pigmentary stone. Now the medications are important. So many drugs can induce hemolysis. That may be autoimmune mediated, antibody mediated, or it can be stress on the G6PD system. So therefore, drug history is very important. Travel will be quite significant. Patient has visited a malarious area or area where babesiosis is common, not in our country, I believe. So infections due to these organisms can be responsible for an entity called febrile hemolytic syndrome. The term febrile hemolytic syndrome refers to patient develops fever and the patient develops hemolysis concurrently. There are a lot of conditions under that, which you will see later. And present infection due to some infection like producing septicemia, Clostridium, that also can result in severe hemolytic anemia. So also important to know the cardiac surgery. If the patient had cardiac surgery, valve replacement, and the patient comes to you with a hemolysis or patient comes with anemia, one of the conditions you will consider will be, two conditions I will consider. One will be mechanical hemolysis, other one will be endocarditis. They can come to you with anemia. So history is very important. Now the blood loss should be important. If the patient is losing blood, acutely if the patient has lost, there will be reticulocytosis without hemolysis. So looking at the reticulocytosis, you are likely to think that there is hemolysis. So this we already seen in the last class. Blood loss will be hemorrhage, will be a cause for reticulocytosis, hyperproliferative type of anemia. Therefore, it can mimic hemolysis because of the presence of reticulocytosis. Discolored urine. Some of the patient with the hemolytic anemia passes red urine. What diagnosis will you make? Anybody? Red urine. Classically, it doesn't produce any colored urine, but hemolytic anemia with red urine. Anybody? Any interaction? Now the answer is intravascular hemolysis. Intravascular hemolysis, we will see that hemolysis occurs inside the vascular compartment. RBCs are just broken inside the vessel, leaving free hemoglobin into the plasma. It will be filtered by the glomeruli. Yes, very good. Hemoglobinuria, somebody has answered. Intravascular hemolysis, lot of causes are there. We will not go into details now. So intravascular hemolysis, patient will come to the red urine. Now family history is very important, obviously. Then history of jaundice, gallbladder disease, splenectomy. All of them should make you think that the patient has got hereditary conditions like thalassemia, sickle, or some hemoglobinopathies. So history is very, very important. Now we come to the types of hemolysis based on the site. You have got extravascular hemolysis and the intravascular hemolysis. Extravascular hemolysis occurs in the reticuloendothelial system. Intravascular hemolysis occurs within the vascular channel. Intravascular. Now, what are the features of each? Let us see what are the differences, what are the common features. Now, what are the common to both of them, intravascular or extravascular? Both of them will produce echoloric jaundice. We already referred to the term echoloric jaundice. which means no bile pigment in the urine. Then reticulocyte production index will be more than 2.5, whether it is intravascular or extravascular. Direct fraction will be less than 15% of the total bilirubin, indicating that it is an indirect hyperbilirubinemia. And of course, there will be anemia. Sometimes there may not be anemia if the hemolysis is compensated. When I say compensated, the rate of lysis is equal to rate of production by the bone marrow. Such situations also we have seen. Therefore, in such a situation where you have got compensated hemolysis with hemoglobin being normal, you will never suspect hemolysis. The clue at that point will be to look for the reticulocytes. So anemia mostly occurs, sometimes may not occur. That is the importance of looking for reticulocyte count in every patient with even a mildest anemia. Very often we miss it. That should not be done because we can uncover hidden hemolytic process because the reticulocyte count is high. And LDH will be high, obviously. And one point to remember is LDH need not always be high. It will be high during the spurt. There will be high rise followed by become normal. So you have to repeat it if the diagnosis is not certain. And urine urobilinogen will be elevated in both intravascular as well as extravascular. And haptoglobin is a condition, is a alpha 2 globulin which mops up free hemoglobin that escapes into the plasma. Free hemoglobin is injurious to kidney. It will produce renal failure. To prevent that, nature has given an alpha 2 globulin which will pick up, form a combination complex with it, which will be ultimately dealt with reticuloendothelial system. So haptoglobin will be reduced both intravascular as well as extravascular hemolysis. So these are the common things. So repeating common things: echoleric jaundice, RPM more than 2.5, direct fraction less than 15. Somebody has answered. Yes, somebody has asked a very good question. Acute phase reactant. I think somebody has asked. I am going to answer that after this. So direct fraction less than 15, anemia plus or minus, LDH high, urine urobilinogen elevated, haptoglobin reduced. Now the problem with the haptoglobin, I think last time I sounded about it. Haptoglobin reduction indicates hemolysis. But in a patient with hemolysis, even in a patient with hemolysis, haptoglobin can be normal. So normal haptoglobin does not rule out hemolysis. Then you have to think about LDH, urobilinogen, direct fraction, and peripheral smear, other things. So a normal haptoglobin can occur because, as somebody has asked, it is an acute phase reactant. Therefore, in a situation where there is some infection happening, it will be elevated. Even if there is hemolysis, it may not be low. That's a very good question. I think I answered. Now come to the extravascular hemolysis. It is very common, whereas intravascular hemolysis is less common. Now the plasma will be clear. Centrifuge the plasma without producing in vitro test tube induced hemolysis. The test tube has to be pakka dry. Otherwise, it will induce hemolysis. We have to be very clear about it. Collection has to be very proper. So it will be very clear. Otherwise, it will be red in color because of hemolysis. So extravascular hemolysis will be characterized by clear plasma. There will not be any hemoglobinemia and therefore no hemoglobinuria in the urine. And hemoglobinuria will lead to hemosideruria. Therefore, there will not be any hemosideruria in extravascular hemolysis. Whereas in intravascular hemolysis, the hemoglobin, free hemoglobin escapes into the plasma. Plasma remains red, and therefore, because it is circulating as haptoglobin hemoglobin complex, so that will impart the plasma red color, and this hemoglobinemia will lead to hemoglobinuria, And hemoglobinuria can be identified by special test for hemosideruria. Significance of hemosideruria will come to later. These are the differences between intravascular and extravascular type hemolysis. Now you look at this chart. This is an intravascular hemolytic event. You will find the serum hemoglobin drops. As somebody has asked, it will not drop if it is an acute phase reactant, it will remain normal or elevated. Otherwise, it comes down rapidly, and within 1 or 2 days, it goes up and reaches within a week or so, it becomes normal. So, initial stages, it will be very useful to find out that there is a hemolytic component happening. Hemoglobinuria happens immediately. The amount of hemoglobinuria will go on increasing, and within 1 or 2 days, depending upon the extent and duration of hemolysis, it will settle down. Then hemosideruria does not happen within the first 2 days because hemosideruria is detected by special strain called potassium ferrocyanide in the urine. You take the urine deposit, then add potassium ferrocyanide K4FeCN6, results in ferric ferrocyanide if there is a iron component in the urine. Normally, it will not be present. When there is a hemoglobinemia, intravascular hemolysis, hemoglobin will be filtered and it will be taken up by the tubular epithelial cells. And the tubular epithelial cells, you make it into a deposit, examine under the microscope after staining with potassium ferrocyanide, K4FeCN6. That will produce a Prussian blue reaction, deep blue color. And it is important that you should look into the cells. Inside the cells, you will find particles of hemosiderin, which is described as Prussian blue reaction. Hemosideruria will occur only after 2 days because it will take some time for the tubular epithelial cells to digest it and convert it, and they have to be shed. You take it, that deposit, and you find the epithelial cells containing hemosiderin, you can stain it and see. And the important point is, it doesn't happen in the early 1 or 2 days, but it will last for several days. All the tubular cells would have taken it up, and tubular cells will be shed. So several weeks it will be positive. So it's a telltale sign of chronic hemolytic, intravascular hemolytic process. And one condition which I already alluded to, paroxysmal nocturnal hemoglobinuria, you always find hemosideruria. Therefore, it has been called perpetual hemosideruria. Perpetual hemosideruria is another term employed for paroxysmal nocturnal hemoglobinuria. So this is about that. And this is a deposit of Prussian blue reaction. Here the slide is defective, that it is not showing the cells, but it is a color. It is important to differentiate deposits of Prussian blue as a deposit outside the cell. No, it should be inside the cell. Unfortunately, this slide does not show a intracellular deposit. I think this may be one. I'm not sure about it. The only slide I got from the net. Okay, that is the importance of hemosideruria. Hemosideruria means it is an intravascular hemolysis. It's also called Pearl stain, P-E-R-L-S apostrophe, Pearl's reaction, which is more common extravascular or intravascular. It is the extravascular hemolysis that is more common. Now, what is the cause of hemolysis? Now we have to analyze the cause of hemolysis in this case. We have seen that it's hemolysis with the crisis, and it is most probably it is an extravascular hemolysis. And how to analyze the cause of hemolysis? For that, you have to enlist the causes of hemolysis. Easy way of identifying or enumerating the conditions are divided into, take the RBC into account. The factors may be within the RBC or outside the RBC. And therefore, you call it as intrinsic or extrinsic. Intrinsic also can be called corpuscular. Extrinsic can be called extracorpuscular. Now, what are the causes of intrinsic corpuscular factors that can lead to hemolysis? One, the hemoglobin itself may be at fault. There are a lot of hemoglobinopathies where you find hemolysis happening throughout life. Hemoglobin. Then you have got the enzymes. There are 2-3 enzymes. Lot of enzymes are there. Important ones are GCSPD deficiency, pyruvic kinase deficiency, and pyrimidine 5' nucleotide deficiency. We'll come to that. So after seeing hemoglobin, enzyme, and membranes, yeah, hereditary spherocytosis is a membrane abnormality. Very good. Fully agree. Then membranes, spherocytosis, elliptocytosis, so many things are there. And sometimes there may be inclusions inside the RBC. For example, malaria parasites, babesiosis. That also can be included in the intrinsic because they come from outside. It can also be included in the extrinsic component. Now come to the extrinsic component. Having finished intrinsic, extrinsic components, they are extracorpuscular. One is the most important, most common probably is autoantibodies, which you call it as autoimmune hemolytic anemia. Then, not to be forgotten, will be the mechanical hemolysis. RBCs go and strike some hard surface or abnormal surface and gets lysed. It can produce intravascular hemolysis. Now, this is also called RBC go and strike, and therefore it will produce fragmentation. It's also called fragmentation hemolysis. Many chemicals, particularly copper sulfate, can produce direct damage to the RBC membrane, or it can damage the enzyme, therefore hemolysis will result. So I am talking about extrinsic, extracorpuscular factors. Then poisons. Many poisons taken may be responsible for lysis. Toxins and drugs. Infections. Many infections. We have already seen malaria. We have seen babesiosis. So many things. So it can produce hemolysis. So easily, for easy remembering, you can divide it into Yes, mycoplasma will definitely produce hemolysis by IgM antibodies, which we'll come to later. Somebody has answered that. Very good. Yes, fully agree. Now, infections. Here I was talking about infection directly invading this one. Infection, you are talking about, you are telling the answer as antibody mediated infection. Mycoplasma, agreed, fully agreed. Okay, so these are the causes of intrinsic factors and extrinsic factors. And metabolic problems like coming from outside, you can have Wilson disease, which can produce a damage. And that is also responsible for hemolysis. Now, corpuscular will be intrinsic, extracorpuscular will be extrinsic. Now, corpuscular factors are mostly hereditary. That underline, yes, uremia, I think it is A54, I don't know who it is. Uremia can produce it, hemolytic anemia, because there are a lot of urinic toxins that may damage the membrane, number one. And it also produces, somebody has asked a question on whether uremia, that's why I'm answering this, it is not in the slide. Uremia will produce a RBC membrane abnormality. What is the membrane abnormality? Can you think of? It produces bursal anemia, BURR. Bursal, correct. Bursals, otherwise called echinocytes. Bursals are otherwise synonymously called echinocytes. ECHINO-cytes, echinocytes. Spursals are acanthocytes. Spursals are common in liver disease, whereas in chronic uremia, you will find bursals or echinocytes. They also can induce hemolysis because membrane is abnormal. Apart from that, there will be lot of toxins, known and unknown, which may be responsible for hemolysis. That's a good answer. And PNH. PNH, I said corpuscular defects are mostly hereditary. PNH is an example which is an acquired cause, acquired clonal disorder, but it is corpuscular. So what is the general rule? Corpuscular are mostly hereditary. Exceptions. There are 2-3 other exceptions. PNH is an exception to this rule that corpuscular defects are mostly hereditary. But PNH is an acquired clonal disorder. It happens around 50 years, 60 years. Acquired clonal disorder, which is corpuscular, characterized by venous thrombosis at different sites. They may come to you with recurrent abdominal pain. They may come to you with impotence. They may come to you with recurrent abdominal pain and hemolysis. May come to you with dysphagia. They may come to you with arterial thrombosis, venous thrombosis. Lot of other manifestations are there. Plus, they can have pancytopenia. So these are the features of PNH. I'm just giving a very brief account only. You can write an essay on that. Now, extracorpuscular defects are mostly acquired. Now we'll go to the next slide. Now, coming to extracorpuscular factors, we will explore one after another. The most common, most important will be antibody-mediated hemolysis, which is called popularly as autoimmune hemolytic anemia. Then you have got mechanical hemolysis, which I have just mentioned, mechanical valves or some graft or some abnormality inside the vascular tree, small vessels area, capillaries, those areas we will come to that later. That will induce because it is going and striking, the RBCs are striking the surface, which is uneven, which is hard, and therefore produces hemolysis. So mechanical hemolysis, which is otherwise called fragmentation hemolysis, goes and strikes and breaks. Then you have got infections, which I already told you. Bartonellosis, not common in our country. Clostridium perfringens may be present here. Malaria, very common here. Babesiosis, less common. I don't think it is commonly found. Now, metabolic, oxygen damage, I already told you. Then physical and chemical agents. Somebody takes some RBC poisons like copper sulfate. It will produce, copper sulfate will produce renal damage. It will produce intravascular hemolysis. It will produce hepatitis-like picture. I have seen patient who has got a reticulocyte reticulocyte count of 30%, bilirubin 30 milligram. That can happen in copper sulfate poisoning. And their patient went to renal failure. In spite of dialysis, patient succumbed. And stings, bites, snake bites and other things also will be injurious to RBCs. They can induce hemolysis. And hypersplenism. It is also something like extracorpuscular factor. The lysis happening inside the spleen. So these are the things which you should explore. Let us see any one of them is present in this patient. So in this patient who has got a hemolytic crisis, on long-standing hemolysis, 18-year-old, let us look at the autoimmune hemolytic picture. Now, it is an important cause of hemolytic anemia. How do you diagnose autoimmune hemolytic anemia? All of us know that laboratory hallmark of immune-mediated hemolysis is dash. What is it? Coombs test, very good. And coming to Coombs test, very good. A positive, it's also called positive direct anti-globulin test. There are two tests, one is direct, other is indirect. What is the difference between the two? Correct, DCT, correct. Direct anti-globulin test indicates that we are detecting the RBCs that are deposited on the RBC surface. Whereas the indirect will be in the plasma. To take the patient's plasma, get it deposited on some normal RBC, then do the test, indirect. So what is more important clinically will be direct anti-globulin test, which is called a direct Coombs test. Now, it will detect commonly IgG on the surface or complement C3 on the surface. So these are important. I said commonly IgG and complement 3, C3 complement, or both. Sometimes it may be both. So it depends on the situation on the earth surface. It is deposited. You determine, you identify it by certain tests, which will come to the next slide. A positive result in a patient with acquired hemolytic anemia indicate that the patient's RBCs are coated with IgG or C3D. C3D, we have got different combinations, subclasses. So IgG or C3D. Now, because it may be IgG, it may be C3, or it may be rarely IgM, still more rarely IgA. Therefore, what is usually done is polyspecific antiglobulin serum is used. So DAT is performed using polyspecific antiglobulin serum. So it will contain anti-IgG, anti-C3D usually. But other components, there are special antiglobulins are available, which will include C3b, C3c, C4, depending upon the clinical situation, but will be available only in the hematology lab, specialized laboratory. So IgA, IgM can be incorporated in the polyspecific antiglobulin serum. What is the common polyspecific anti-serum used? It contains only IgG and anti-C3D antibody. Somebody has answered something. Prepare from rabbit serum. I am not very sure about it, so I don't venture to answer that. I can't guess it and answer because I should not contaminate you. Maybe I will answer it later, some other class. Anyway, I'm not answering that. Not sure about it. Then you go to the next slide. You have got a polyspecific serum and anti-serum. Then you can use specifically anti-IgG, anti-C3D, anti-IgA. So they will narrow down the possibility and identify whether it is IgG, identify whether it is C3D or IgA or IgM. So it can be should be tested at two levels. One is polyspecific. Then you go to monospecific to identify the exact type of antibody on the surface of the RBC. So direct antiglobulin test or the direct comb test detects antibody or complement already on the red cell surface, where sensitization has already occurred in vivo. Now regarding the test, you have got RBCs, patient's RBC, coated with antibody that is circulating, then take it and mix it with antiglobulins. That is antibody to these antibodies. And this is the bluish color. I don't know whether you can see it. After mixing it and incubating at a particular temperature, what will happen is this will form a bridge. So this will bridge the antibody of one RBC, antibody of another RBC. This is bridging. This is the blue color. This is the antiglobulin we have used. This is bridging. One antibody on the surface of one RBC, another RBC here. So this forms something like rosette, and you get agglutination in the, that's indirect Coombs rules out extravascular. Not necessarily. Question is, does indirect Coombs test rules out extravascular hemolysis? It does not. No, it does not. So coming back. So mixed with the antiglobulin, you find antibody and RBCs joined together to form agglutination. If you find agglutination, you will find that this is a positive test. So AIG reagent is added, wash the red cells, and agglutination indicate positive test. A positive test occurs in hemolytic disease. Not only that, autoimmune hemolytic anemia, there are similar conditions. One is hemolytic disease, the newborn, then autoimmune or drug-induced human hemolytic anemia. Many drugs I told you, extrinsic factors, drugs will produce autoantibodies, they will act as hapten, partial antigens. They get deposited some interaction with the surface membrane and they alter the surface membrane, produce antibody. So drug-induced hemolytic anemia can be due to hapten-like reaction or something called innocent bystander reaction. And the hemolytic anemia will result as a result of antibody to the combination of drug with the RBC membrane. So that is also to be, it will be positive. Then hemolytic transfusion reaction also it can be positive. But in the clinical context of anemia, where we are usually investigating, if we find direct antiglobulin is positive, it indicates autoimmune hemolytic anemia. And you should know that autoimmune hemolytic anemia, Coombs can be negative. It's a rare situation, it occurs. Just because Coombs test is negative, other clinical picture is in favor, you cannot rule out hemolytic anemia, autoimmune hemolytic anemia. Conditions are when one point, the number of RBCs on the surface of the RBCs are very important. There is a threshold value. If the RBC contain more than 200 antibody molecules on the surface, it will give a positive test. Suppose it is 150 cells on the surface, test will be negative. So you will say Coombs is negative. But actually patient is having autoimmune hemolytic anemia. So I am talking about situation where Coombs negative hemolytic anemia. Coombs negative hemolytic anemia. Maybe pre-zone, post-zone phenomenon. In the books I read so many hematology books. I did not come across that. So I will not be able to answer that. Somebody has answered about PNH. Just answered PNH, but I don't know what was intended by it. Can you please clarify? I will discuss other things and then we'll come back to that. So, and now I am discussing Coombs negative hemolytic anemia. So, number of molecules of antibody deposited should be more than 200. If it is less than 200, you will not get it. But at the same hemolysis will happen based on autoimmune hemolytic anemia will happen. Number two, RBCs are deposited and there is a spurt of hemolysis. So the RBC, RBC that contain the antibody or everything disappeared. So the fresh RBCs have come to the peripheral smear, which has not yet been deposited. So you will find that situation after a spurt of hemolysis, the antibody would not have sufficient number reach the surface of the RBC. Therefore, it will be the negative. And I told you about IgG C3D. If the autoimmune hemolytic anemia is due to IgA, if it is due to IgM, using these two components, IgG and C3D, you will not get it. So if the suspicion of hemolytic anemia, autoimmune hemolytic anemia is strong, you have to use the polyspecific anti-serum where you use C3D, IgG, C3D, IgG, IgA, IgM and others. So in that case also you will miss, you will get a Coombs negative, but still it can be autoimmune hemolytic anemia. This is given in Davidson, you can go and look up. Yeah, I understand the prozone and post-zone, that is pre-zone and post-zone phenomenon. I understand that. Whether it is operating here, I am not sure about it. That's what I said. In the textbook, what I read, 3-4 hematology book I read, it not mentioned, it may be possible. Any antibody, you got a antigen excess producing solubilization, antibody excess producing solubilization of the complex, then you call it as a pre-zone and post-zone phenomena. I understand that for other antibodies. Here I not read it. So without reading it, I cannot just give a authentic answer, cannot be given. When I give an answer, it should be, I should have a reference. That's what I said. Your question is well taken, but if since I have not found it in the book, many hematology books I have read it, but I have not come across, so I will not be able to give an answer based on reference. That's what I said. Okay, that is a very good question. Now we go to the next slide. Then there are warm hemolytic anemia. You should know that warm autoimmune hemolytic anemia and cold autoimmune hemolytic anemia. Let us see what are the features. Warm autoimmune hemolytic anemia. Warm autoimmune hemolytic anemia, usually most of the time it is IgG. Warm autoimmune hemolytic anemia, the deposited antibody on the surface is IgG. Now, it will be IgG positive. If you see polyspecific antiserum or monospecific IgG, it will be positive. But usually C3 can be negative or positive. So IgG is positive. C3 testing will be also can be positive, sometimes negative. That depends. But IgG will be definitely positive. And usually we find spherocytes. So warm autoimmune hemolytic anemia is characterized by IgG positivity, Coombs test, C3 positive or negative, and spherocytes. Spherocytes are abundant. And most common cause of spherocytosis will be autoimmune hemolytic anemia. Now come to the cold agglutinin disease. Cold agglutinin, on the other hand, it is not IgG, it is IgM. That you should remember. Now IgG negative, IgG will be negative. If you do test with the IgG antiserum, it will be negative. But C3 will be positive. And another feature peculiar to cold agglutinin disease is erythrocyte autoagglutination. If you take a smear, you find lot of agglutination in the peripheral smear. It isn't clinically in favor of cold agglutinin disease. Can anybody tell what is IgG cold agglutinin? IgG usual MCQ. Cold agglutinins are mostly IgM, except dash. What is the cold agglutinin? That is IgG. Anybody? Somebody? Anybody? DL antibody. You remember that? Donat-Landsteiner antibody. Donat-Landsteiner antibody is IgG cold agglutinin. It is an exception to the rule. So warm agglutinins are IgG, cold agglutinins are IgM, but exception to this rule is IgG cold agglutinin occurs in Donat-Landsteiner antibody. Donat-Landsteiner antibody, where does it occur? Olden day when we were students, it is in syphilis. Now, not necessarily in syphilis, it can occur in viral infection, particularly in children. Just viral infection can induce Donat-Landsteiner antibody. You need not think about only syphilis. You can think of viral infection, short-lasting viral infection can induce, some of them induce, and syphilis cannot be forgotten, sometimes malignancy. So this you have to think about it. So cold agglutinin IgG is Donat-Landsteiner antibody. Now this is the typical cold agglutinin producing autoagglutination in the peripheral smear. You find all of them are clumped together. If you get such a picture, your first diagnosis, if the smear is prepared well, still you get such a phenomenon, your diagnosis is cold agglutinin problem. Whereas in the warm agglutinin variety on my left hand, you have got lot of spherocytes. There is no clumping as we see in the other slide. Lot of spherocytes. Spherocytes we can identify because they are small in nature. Therefore, you call it as microspherocytes. There is no central pallor. They are not biconcave, they are spherical. They are called spherocytes, microspherocytes. Without the central pallor, it's not biconcave. And you don't find autoagglutination. Where on the right side, you find autoagglutination in abundance. So on the left hand, you have got warm agglutination. On the right hand, you have got cold agglutination. So this patient had a childhood onset chronic anemia. There is no such peripheral smear appearance described as either cold picture suggestive of cold agglutinin or autoagglutination. No spherocytes. Coombs test was negative. So therefore, in this patient with suggestive of hemolytic anemia, we are ruling out by Coombs test and other features that it is not autoimmune hemolytic anemia. Yes, somebody has said that PowerPoint should be given. I definitely am going to give it. The 3 classes I taken, I will send it. I think I'll send to Dr. Kishan Rao. I think he will share with you. No doubt about it. I will do it. By quality, being an elderly, the quality of slides may not be as good as you make it. For you have to excuse me for that. I will definitely give it. I was a little reluctant because quality is poor. You tolerate it, I will definitely give. I'm going to give it. Don't worry. Somebody has asked me the other day, so I will definitely give. No worries. Now come to the mechanical causes. Now the mechanical causes produces, as I already told you, what is called a red cell fragmentation syndrome. In the vascular channel, there is some abnormality. RBCs go and hit it and get lysed. That is the feature of red cell fragmentation syndrome. It may be a physical damage or a mechanical damage to red cells, either on the abnormal surfaces. For example, you have got an artificial heart valve, mechanical heart valve, processes in place, aortic valve, mitral valve, and the RBCs are going to hit it. It is a mechanical, it is not usual smooth endothelium. Therefore, it will get lysed. Arterial graft, however smooth you make it, it is artificial. Therefore, it will produce some damage. So, arterial grafts, sometimes venous graft, artificial heart valves, all of them will produce, can produce red cell fragmentation. Not everybody, some people it produces. Then arteriovenous malformation. The vasculature is entirely different from the normal. Therefore, it can produce abnormality, and sometimes microthrombi occur in certain situations of fragmentation syndrome. Typically, it is HUS, it is TTP, and it is TTP, HUS, and DAC. Small thrombi occur. They will hinder the passage of RBCs. They hit it and get damaged, and they get lysed. Now it occurs these 3 things. That are 3 things I mentioned now: HUS, TTP, and DAC. They are the classical microangiopathic hemolytic anemia. Micro means small vessel, angio occurs small, angio vessel, hemolytic anemia. So vessels, the small vessels are filled with some fibrin strands, microthrombi, and therefore there is a damage at that level. Therefore, it is called microangiopathic hemolytic anemia. So I already told you DIC, HUS, TTP. Caused by red cell passing through these abnormal small vessels. That is what is happening. Let's go to the next slide. Now, what are the causes of red cell fragmentation syndrome? It can be a short note, may not be essay. TTP, HUS, DAC already told you. Then disseminated malignancy. Maybe there are intravascular deposits of RBC, intravascular deposits of malignant cell. Some alterations happen in the capillary level. Disseminated malignancy is one of the causes of mechanical hemolysis. That is fragmentation, red cell fragmentation syndrome. Anti-M3. I didn't follow that. AML M3. Okay. Sorry. March hemoglobin. Yes, very good. March hemoglobin, I fully agree. I just left it. Very good. March hemoglobin can be added for mechanical hemolysis. Okay, that's good. You have written AML M3. AML M3 usually produces DAC. Agree. For the DAC, it is good. A malignancy that produces leukemia that produces DAC is another question, another MCQ. Very good. He brought in. And it is AML M3 will produce disseminated intravascular coagulation. And disseminated malignancy, it can also produce DAC. It can also produce fragmentation hemolysis. Vasculitis, particularly, it is an inflammation. Therefore, in the smaller vessel, it can produce damage-creating surfaces. Therefore, RBCs can be fragmented. It's malignant hypertension, we may not remember. Patient who has got malignant hypertension, severe hypertension, hypertensive encephalopathy, papilledema, this constellation, you call it as malignant hypertension. The vessels are abnormal, and therefore RBCs hit at it and undergo hemolysis. Now, preeclamptic toxemia and HELP syndrome, there also you find there can be microangiopathic hemolytic anemia. Then renovascular problems, Also, it can produce microangiopathy, hemolytic anemia, or red cell fragmentation syndrome. And drug-induced fragmentation syndrome, microangiopathy, hemolytic anemia is not, particularly cyclosporin. So other drugs are also present. Have been described. Clopidogrel has been described. Here, I have taken as cyclosporin as an example. So drug-induced has to be remembered. Then homograph rejection. There may be vessel surface, endothelium can be damaged. Therefore, it will produce red cell fragmentation syndrome. Then there is an entity called complement mediated thrombotic microangiopathy. Details you need not know, just know that DMAS stands for thrombotic microangiopathy. There is a thrombosis at the microsite, therefore thrombotic microangiopathy. It is mediated by complement. There are several causes for that. We will not go into that. So complement mediated thrombotic microangiopathy. Then I already told you mechanical valves, which produces particularly paravalvular leaks and arterial graft. I have mentioned about it. And the first class on red urine, I described about a mitral valve replacement with a paravalvular leak. And that syndrome was called Waring-Blunder syndrome. Waring-Blunder syndrome refers to mechanical hemolysis after replacement of a valve, mechanical valve, and particularly it happens when there is a paravalvular leak. When there is a paravalvular leak in the mitral area, there will be jet from left ventricle to the left atrium. And when the RBCs are going with a high velocity on the mechanical surface, mechanical area, mechanical surface of the valve replaced, you will find they undergo lysis. That is called Waring-Blunder syndrome. W-A-R-I, Waring, W-A-R-I-N-G, Waring-Blunder, B-L-E-N-D-E-R, Blunder syndrome. I think I described it in the first class. That is the diagnosis, ultimate diagnosis for a red urine in that case. Then, of course, arterial graft. So, red cell fragmentation syndrome can occur in multiple situations. TTP, HULDAC, most common. Disseminated malignancy, most important. Disseminated malignancy, vasculitis, malignant hypertension, preeclamptic toxemia, HELP syndrome, renal vascular disorders, drug-induced, cyclosporin, homograph rejection, and complement mediated TMA, and mechanical valves and paravalvular leaks and arterial grafts. So this is the summary of a red cell fragmentation syndrome. Now, what are the common features? Essential features are: one is mechanical hemolysis. Number two is shear stress. So it is happening, it is going through a fibrin strand going along the surface of a mechanical valve, metallic valve, and therefore fragmentation occurred. And most characteristic feature that tells you that it is a fragmented syndrome is schistocytes. That is the most important point you should remember, schistocytes. And of course, it will produce unconjugated hyperbilirubinemia, and sometimes, not infrequently, it can produce thrombocytopenia, maybe again due to shear stress. Now, hallmark of MAHA is schistocytes. Hallmark of MAHA is schistocytes. And it's not occasional schistocyte, it should be more than 1% of the total number of RBCs. Only if this is guaranteed, you can say that significant number of schistocytes have been identified. We are therefore dealing with mechanical hemolysis or fragmentation hemolysis. Now, fragmentation again, the point. Now, just few points to distinguish between HUS, TTP, and DAC. This is a very common question in the MCQ. Now, all of them will produce indirect hyperbilirubinemia, no doubt about it. All of them will produce LDH high. Thrombocytopenia is common to all the three. Schistocytes are common to all the three. So, what is the difference between clinical difference among these three? HUS, TTP, DAC. So, first four component, indirect hyperbilirubinemia, LDH high, thrombocytopenia, schistocytes are common to all the three. If uremia is present, it is in favor of hemolytic uremic syndrome. If CNS manifestation with altered sensorium and focal deficit do not usually happen, there can be convulsion. Focal deficit do not occur because the microvascular is affected, so hemiplegia, other things do not happen. CNS manifestation mainly altered sensorium, convulsion, without much focal deficit. If that is there, it is TTP. And you should know that there is a spectrum of HUS one end and TTP another end, and there can be overlap between the two. So it is HUS TTP constellation syndrome. So it may be a combination of either of them. You have an overlap with both components. So common things I have told you, but CNS manifestation predominating it is TTP, whereas HUF it is uremia predominating. Now DAC will be characterized by, apart from the four components, you have PT, APTT prolonged because it is a consumption of the coagulatory factors. So if PT, APTT is prolonged, definitely it is in favor of a DAC. No, TTP can be inherited or acquired. So Adam 313 deficiency, that one protein is a metalloproteinase. That deficiency can be congenital or antibody mediated. So it can be congenital or acquired. Both have been described. Now, for some reason, even though it is congenital, some precipitating factors happen and it triggers TTP. And as a part of autoimmune disorders, TTP can occur because antibody to Adam 313, that protein, metalloproteinase occurs. Therefore, its activity comes down. So both are described. It can be congenital or it can be acquired. Now, in every hemolytic anemia, therefore, you should look for schistocytes and thrombocytopenia. Schistocytes and thrombocytopenia. I'm very happy that there is a lot of interactions. That is something which gives us a boost, gives the teacher a boost. Thank you so much. Now go to the next slide. In this patient, we can eliminate all fragmentation disorders causing hemolytic anemia because we never found any schistocytes or any of the features which I have described now. No schistocyte, no thrombocytopenia, no prosthetic wall, no AV malformation. Clinically, none of the conditions I mentioned in the last few slides are present. Therefore, we eliminate fragmentation hemolytic syndrome. Now come to the infections. Lot of infections are there. Some of them are important in our center, some of them are not important. So I will just skip it because unimportant things I will leave it. Malaria is important because it can produce febrile hemolytic syndrome. Babesia also will produce febrile hemolytic syndrome. All of them, babesiosis, Bartonella, Clostridium perfringens, we will take it up later. All of them producing febrile hemolytic syndrome. Now, infection will take it up later as extracorpuscular, no intracorpuscular. Metabolic, oxidant damage, enzymopathies come to the next point of the extracorpuscular. Physical chemical agents, copper sulfate poisoning, some stings and snake bites. None of them are here. None of them are here. Therefore, we can eliminate that. GCSPD, yes, GCSPD is you can put it under pyruvate kinase. GCSPD you can put it under GCPD you can put it under corpuscular as well as extracorpuscular. Because you give an oxidant drug, it becomes extracorpuscular. There is a overlap between corpuscular and extracorpuscular in certain situations. For example, if you take malaria, malaria comes from outside, so it is extracorpuscular. But it produces inside the RBC, there is an inclusion, so you can put it under that also. So that's why I am discussing at later time. So most important, you have mentioned GCSPD. I think some Chandra, Armuga Chandra. Yeah, he has said about GCPD and pyruvate kinase. These are the two important enzymes. We will come to that later. So we didn't have any copper sulfate poisoning, stings or snake bite, and it cannot explain hemolytic anemia going on for 18 years. So we can eliminate that. Hypersplenism, spleen was not palpable at all. Hypersplenism, it produces pancytopenia, bicytopenia, or monocytopenia. Most common will be to produce thrombocytopenia, then anemia and leukopenia. All the three can happen in different combinations. And you will find bone marrow shows erythroid hyperplasia. So marrow is full, spleen is palpable, and empty blood. That is usual descriptive term for hypersplenism. What is it? Large spleen, Number 2, empty blood. That means hemoglobin is lower and full bone marrow. That means there is a hyperplasia as a compensatory mechanism. This is the picture of a hypersplenism. Anyways, spleen is not enlarged, so that is not a question. Now come to the corpuscular. So we have eliminated one after another antibody mediated fragmentation, poisons, all of them have been eliminated. So the patient who got hemolysis not due to an extra corpuscular factor. We didn't find anything. Therefore, we go to the corpuscular factors. Now, corpuscular factors, you take up the membrane. Now, in the membrane, you have a lot of membrane abnormalities. It may be spherocytes, it may be elliptocytes, or there are things which do not happen in our country, but MCQ sake you should know about Southeast Asian ovalocytes and acanthocytes. Acanthocytes we do come across, not related to any particular area. So we'll discuss one after another. Now, corpuscular membrane, reticulospherocytes, elliptocytes, ovalocytes, acanthocytes. Now, how do you identify the corpuscular membrane defect? Very easy, identified by peripheral smear examination. Therefore, in a patient who has got hemolytic anemia, peripheral smear examination is very, very important. And moreover, it will give indirect clue to the peripheral smear examination, to the hemolytic anemia. Can anybody mention what are the findings you can get in hemolytic anemia common to all causes of hemolysis? Not for schistocytes or other things, but any hemolysis you can get it. But all findings need not be present. Can anybody mention one or two? Then I will start. Somebody has answered. Two answers have come. Hubble-Jolly bodies increase reticulocyte count. Agreed. Hubble-Jolly bodies also may be present in some of them, but that is specific for certain areas. Common things will be, one is increased reticulocyte count. I think I want to just correct it. Reticulocyte count will not be found. Reticulocyte will not be found in the peripheral smear as reticulocytes. How do they appear? How does the reticulocytes appear? Many students think that reticulocytes will appear in the peripheral smear. It will not be present. We are today a special stain using a wet preparation, glazing crescent blue. Even not nucleated RBC. Somebody has written nucleated RBC. It has to be corrected. It is polychromasia. Because they are immature, they have got a blue color as well as a red color. Polychromasia is a representative of reticulocytes in the wet preparation. Polychromasia, many books put it as polychromasia bracket reticulocytes. Reticulous in the wet preparation. Yes, green color stain is actually blue. Agree. So the appearance, RBC appearance will be polychromasia indicating reticulocyte. Then definitely you do the reticulocyte count. So polychromasia is one. RBCs are stimulated. So somebody has correctly put, I think somebody has put it as a nucleated RBC. You get normoblasts. So RBC, regarding RBC, you get polychromasia representing the reticulocytes. Agree. Supravital stain, correct? Supravital stain you have to do it, but not in the peripheral smear. So what you do is take a wet preparation, add a particular concentration. There are procedures for that. We need not know. Pathologists will know it. Then you add supravital stain. Look under the microscope under wet preparation. Put a cover slip, wet preparation, count the number of 100, and out of it, how many have got reticulum cells? There you can find the cells in a reticulate fashion. So that is the one that you do. That corresponds to polychromasia in the peripheral smear. Then as she has put it, nomoblast. Nomoblast indicates the RBC series have been stimulated. The younger ones are appearing, seeping into the bloodstream. Regarding the WBC, you can find WBC can increase as well as there can be a shift to the left. Shift to the left. Some unusual but can happen. There will be a shift to the left. There can be a shift to the left with a promyelocyte, metamyelocyte appearing in the smear. And bone marrow is stimulated. So there can be thrombocytosis. You find larger number of thrombocytes. Thrombocytes can be counted in the peripheral smear by specialists. It is possible. If you don't have a counter in the periphery, you can count it. So you can get some evidence of thrombocytosis. You can get polycythemia, nucleated RBCs, and shift to the left and WBC high. These are the common things that can occur in every patient with hemolysis. Now, I did not ask about the specific thing. We'll come to that later. Now, peripheral smear examination also will detect membrane abnormalities. The normal red cell peripheral smear. Now, this is the micro hereditary spherocytosis. You can find RBCs are small and at the same time log the central pallor, indicating that it is a spherocyte. So, spherocytosis can occur in hereditary, it can occur in autoimmune hemolytic anemia and few other conditions. We will come to that later. Now, again, this is a typical autoimmune hemolytic anemia with a large number of microspherocytes. They are necessarily small. They are called microspherocytes. Occurs, most important condition is autoimmune hemolytic anemia, then hereditary spherocytic, few other conditions which I will be dealing with later. Now, spherocytes are round cells with loss of central pallor that you should remember. Pointed arrow is there. Some answer has come. Yes, small lymphocyte. RBC size have to be combined with a small lymphocyte. Fully agree. Fully agree. Chandra, some dash. Arun Baba Chandra has answered that correctly. RBC is to be compared with a small lymphocyte. Fully agree. Go to the next slide. Most important clue for spherocytosis, increased MCH. That is an important point. Cells are rounded, smaller, spherical with no central pallor. So this is the biconcave cell RBC. The cytoskeleton is lost. It assumes a spherical appearance and it also becomes smaller. That is the appearance of a spherocyte. Now conditions are hereditary spherocytosis, then autoimmune hemolytic anemia. Most common will be autoimmune hemolytic anemia. Burns it can produce, but clinically there is no difficulty in diagnosing. It's not a diagnostic problem. It happens. Clostridium perfringens septicemia, Zeev syndrome. One more thing is sometimes snake bite produces some phospholipase and all that. RBC membranes are damaged. That also produces spherocytes. So, hereditary spherocytosis, autoimmune hemolytic anemia, Clostridium perfringens septicemia, you find this type of cells, and Zeev syndrome also. We'll come to Zeev syndrome later. What is the clue for spherocytosis? Most useful parameter, I already told you, assessing spherocytosis is MCHC more than 36 gram per deciliter is consistent with spherocytosis. The only condition probably, which as a general physician knows, is only spherocytosis that produces a very high MCHC, mean corpuscular hemoglobin concentration. If it is more than 36 gram per deciliter, you can assume that the patient got significant number of spherocytes in the circulation. Now, coming to the test. This is a very popular test, osmotic fragility test. And in the x-axis, you have got saline in various concentration, 0.2 gram per liter, 0.4, 0.6, 0.8, 1 gram, 1.2 gram per deciliter. The rightward, as you move to the right side, more and more concentrated. On the y-axis, you have got the lysis percentage, 0, 20, 40, 60, 100. Now look at a normal. Normal is given by the black color. Lysis starts here. That's about 0.75, something like that. This is a 0.8, this point is 0.6. At 0.75 only it starts and becomes 100% lysis within a short time. This is the normal. This is the control also. Control normal, both of them, all the three are starting somewhere here. Whereas the spherocytosis, when it is subjected to osmotic strain, it starts lysis at a higher concentration. That means osmotic fragility is increased. It is starting at about 0.9 Lysis starts here and complete by 0.6. By 0.6, the normal RBC starts lysing only. It starts only at 0.7. By the time in a patient who has got a spherocytosis at 0.7, it is almost 100% lysed. Every spherocytes are lysed. So the classical test which I will use for years together will be osmotic fragility test. There is also some modification called incubated osmotic fragility test, which increases sensitivity. There it starts at 0.9 instead of the normal 0.6 or 0.65. So this is the classical test. Then there is one more test which has come up. One is eosin 5-maleimide binding. By this, you can, using flow cytometry, you can find that spherocytes are identified by a separate heap of structure here. It's all computer made. You find normally there will be a peak like this. If you find this is shifted to the left side, it indicates that there is a spherocytosis. Similarly, another test. So what is the test known as EMA binding, eosin 5-maleimide binding using flow cytometry. So normally you find something like this. Here you find it goes to the left side. And there's also one more test called ectocytometry. Ectocytometry, that's also a newer test, may not be available everywhere. High-tech hematology lab, it will be available. So this you should know. Now come to the hereditary elliptocytosis. This is the elliptocyte. All of them are, many of them are abnormal. This also can produce hemolysis. Again, elliptocytosis. Then there is something called pyropoikilocytosis, temperature dependent lysis, along with elliptocytes. Not going to the details. So we don't have any such abnormality in this patient. Then there is something called stomatocytes. Stoma means mouth. You have got something like a mouth here. Hereditary stomatocytosis, that also can lead to hemolysis. All can be identified by peripheral smear examination. Now, just summarizing, test for spherocytosis may be useful for examination. Traditional test is osmotic fragility test. Osmotic fragility is increased. The early hemolysis where normal RBCs can be struck. Agree, fully agree. Chandra has made the correct explanation. I fully agree with you. Traditional test for hemolysis, osmotic fragility, EMA test, eosin 5-maleimide binding using flow cytometry. Then I told you about ELKA cytometry. This is osmotic gradient ELKA cytometry. 1 minute. Osmotic gradient ELKA cytometry is a very sensitive and more specific phenotypic test, especially in differentiating hereditary spherocytosis from other RBC membrane defects. We have seen so many types of RBC membrane defect. This EKTA cytometry test can differentiate between spherocytosis and other membrane defects. Supposed to be high-tech test, which I don't think many of the hospitals have it. So that we should remember about it. The eosin 5-maleimide test uses flow cytometric studies. That also you should know. That's also very sensitive screening test for hereditary spherocytosis. ELKA cytometry will differentiate among them. There are different curves for each. That is a job of a hematologist, none of us. Then you have got elliptocytosis. Elliptical nature, that also can lead to hemolysis. This is Southeast Asian ovalocytes. There are 2 stoma. Again, it can lead to, it's not a problem in our country, I believe. Now come to the acanthocytes, which we will see not infrequently. Chronic liver disease is a very common condition which produces Spursal anemia. Acanthocytes are otherwise called Spursal. Acanthocytic anemia, otherwise called Spursal anemia, occurs in chronic liver disease. Chronic liver disease, Spursal anemia, it's an indication actually, olden days indicate for transplant. Now there are other indications for liver transplantation. Therefore, we may not see a sparsal anemia because most of the people will be, many people will be subjected to transplant in the modern era. Therefore, but still you can see in our country. Now there is a bucleoid phenotype that produces acanthocytes. Then neuroacanthocytes, there are different multiple combinations are there. I am not going to that. But just understand neuroacanthocytes, cytosis, characterized by chorea as well as acanthocytes. So when there is a chorea, genetically determined condition starting from childhood, look for peripheral smear acanthocytes. Similarly, A beta lipoproteinemia, again you can have acanthocytes along with malabsorption of fat, vitamin E deficiency, cerebellar disorder, and retinitis pigmentosa. So whenever there is a cerebellar disorder, posterior column problem in combination with the retinitis pigmentosa, always look for vitamin E level as well as look for acanthocytes. It may be a case of A beta lipoproteinemia. And there is something called a Zeev syndrome that also can produce acanthocytes. I already told you Zeev syndrome can produce spherocytes. It can also produce acanthocytes. What is Zeev syndrome? We are coming to that. Then rarely hypothyroidism can produce, according to the textbook, but I have not seen one. Acanthocytes can occur. These are common conditions. Maybe we get it sometime. Correct. Yeah. Shambhavi has mentioned alcoholic jaundice hyperlipidemia. Very good. That is the answer for Zeev syndrome. She has already answered. I think I need not go into that. Now, this is the acanthocyte. This looking at it, I am reminded of this rose stone appearance. Looks like, whereas echinocytes or the burr cells, which is characterized uremia, it looks like the cactus plant. Cactus. You've got very spinous, regularly spaced spicules. Very fine. This is a little broad at the base. Just like rose stone, other one is like the cactus. Now, Zeev syndrome, she has already told about it, still I will give a few points. Zeev syndrome, it's an alcoholic problem. What is Zeev syndrome? It is alcoholic cholestatic jaundice. And there is hyperlipidemia. And there is hemolytic anemia. So, what are the constellation? Alcoholic cholestatic jaundice and hyperlipidemia, which is often transient. Sometimes it may disappear within a short time. So, you may not get it. And hemolytic anemia. And alcoholic hepatitis, yeah, same combination. So, this is a situation where you get conjugated hyperbilirubinemia with reticulocyte production index high. Usually, reticulocyte production index is high in hemolytic anemia, which is unconjugated. This is a peculiar situation where you can have conjugated hyperbilirubinemia, urine bile pigment will be present, at the same time reticulocyte production index is high. That is because there is sparsal that is happening, spherocyte that is happening. So there is a hemolysis, there is a conjugated hyperbilirubinemia and hyperlipidemia. This combination occurs in alcoholic hepatitis, some of them turning into Zeev syndrome. So this is a picture showing spherocytes and acanthocytes in Zeev syndrome. So you can have acanthocyte, you can have spherocyte, also schistocytes. So all the three can occur, which can lead to hemolysis. What are they? Zeev syndrome will be alcoholic hepatitis, cholestatic jaundice, hyperlipidemia, which can be transient, and hemolytic anemia due to acanthocytes, schistocytes, and spherocytes. It alters the membrane and therefore produces havoc. Now the question is, Zeev syndrome, I already told you, it's a conjugated hyperbilirubinemia with reticulocytosis, very unusual combination. Can you have it in other conditions? There are few conditions which I have been found to be useful in making diagnosis of certain problem cases. We come to that. I think you should know about it. One is infectious mononucleosis. IMN can produce IgM antibody, autoimmune hemolytic anemia. And IMN also is a cause for hepatitis. So if you have got a hepatitis, you get conjugated hyperbilirubinemia. At the same time, IgM mediated chlorhydroplatin can occur, therefore produces reticulocytosis because of hemolytic anemia. So you can have a conjugated hyperbilirubinemia with reticulocytosis in IMN. Second condition, again for the same reason, mycoplasma. These are the two important common infections where you get IgM called agglutinin. Then Wilson disease. Wilson disease should be considered every case of hemolytic anemia where the cause is not identified. It can present with hepatitis-like picture, conjugated hypervolemia, later neurological disorder like Parkinsonism or choreoathetosis or cerebellar, many of them. But Wilson disease also is cause for hemolytic anemia. Any unexplained hemolytic anemia where there are no spherocytes, no acanthocytes, no GC-speed deficiency, no Heinz body. So Heinz body negative, Coombs negative, autoimmune Coombs negative hemolytic anemia where no cause is found. Consider particularly young children or patients Wilson disease because free copper is an erythrotoxin. So here you can have a patient who has got hemolysis happening. At the same time, liver is damaged. So you can have a conjugated hyperbilirubinemia along with hemolysis. So reticulocyte count will be high. Again, copper sulfate poisoning. Copper is an erythrotoxin. It is a hepatotoxin, it's a renal toxin. Therefore, copper sulfate poisoning can produce reticulocytosis as well as hepatocellular type of jaundice. Malaria will produce febrile hemolytic syndrome. Therefore, it will produce hemolysis and reticulocytosis. Sometimes reticulocytes may be suppressed because of cytokines and other things, but often it may happen otherwise. So reticulocytosis can occur. And if it is particularly falciparum malaria, organs can be affected, liver cell dysfunction and hepatocellular jaundice can definitely occur. So you can have a combination of conjugated hyperbilirubinemia along with reticulocyte high. A patient who has been having next condition where you get combination of conjugated hyperbilirubinemia with gallbladder, so with reticulocytosis will be somebody has got a chronic hemolysis, thalassemia, sickle cell. They develop gallstones. Gallstone goes and obstructs. What does it produce? It will produce obstructive jaundice, which is conjugated hyperbilirubinemia. And already have the patient background is having reticulocytosis with hemolytic anemia. So this combination can occur in this situation also. Autoimmune hemolytic anemia may be combined with autoimmune hepatitis. That can occur. Both are autoimmune. Then rifampicin can produce hemolytic anemia. Rifampicin can produce hepatocellular jaundice. Therefore, conjugated hyperbilirubinemia and reticulocytosis can go together. Now, patient with the hepatitis, patient is having GC-speed deficiency. A patient who is having GC-speed deficiency develops hepatitis. Any infection can precipitate GC-speed deficiency hemolysis. Therefore, you can have a hemolysis, reticulocytes high, and there is a conjugated hyperbilirubinemia. So, what are the conditions you should think of when there is a conjugated hyperbilirubinemia with reticulocytosis? Infectious mononucleosis, mycoplasma infection, Wilson disease, copper sulfate poisoning, malaria, chronic hemolysis with gallbladder stone, autoimmune hemolytic anemia, autoimmune hepatitis together, drugs like rifampicin, hepatitis in a patient with GC-PD deficiency. This is a pure combination, but at the same time, I have found it to be useful multiple times. So problem cases when you are stuck, have such combinations in your practice. So we have ruled out corpuscular membrane defects. Now we come to because there are no spherocyte, no elliptocyte, no ovalocyte, no acanthocytes. So membrane-related cause of hemolytic anemia, all will have abnormality in the peripheral sphere. Hence, all of them in this case stand ruled out. Now come to the enzymopathies causing hemolysis. Enzymes, erythroid enzymopathies are three important enzymes. One is GC-PD, pyruvate kinase deficiency, and pyrimidine 5-nucleotidase deficiency. What are they? GC-PD deficiency, pyruvate kinase deficiency, These two are most common. Pyrimidine 5-nucleotide deficiency. That is less common. I brought it because there is some point to be taught. Go to the next slide. GCPD deficiency. There are three types of presentation. Acute hemolytic anemia. Suddenly the patient develops hemolysis. And it can start as neonatal jaundice. And congenital non-spherocytic hemolytic anemia. So 1%, these are the three types of presentation. Now, acute hemolytic anemia, this is the most common presentation. For some reason, suddenly the patient who is normal, hemoglobin 40 gram, goes into hemolytic crisis, acute hemolytic episode. Now, you should remember that is X-linked. Therefore, you get more in females, predominantly affected. Acute hemolysis will occur in response to any oxidant stress. Oxidant stress can be in the form of drugs. You give lot of drugs. Polypharmacy is the rule nowadays. So many drugs can precipitate it. You got a list of drugs, no need to mug it up. Fava beans is particularly notorious to produce oxidant stress and therefore it produces hemolysis in them. Many infections can precipitate hemolysis. We already seen the last slide, hepatitis developing in GCPD deficient patient. So any infection, many drugs, fava beans, and other oxidant drugs can precipitate acute hemolysis. Important point to remember is it is self-limiting. You get a spurt of hemolysis when you take a drug or when there is an infection. After that, it is quiescent for years together, nothing will happen. So self-limiting. It will not go on for years together with the chronic anemia. Most individuals are often asymptomatic with normal hemoglobin. So normal hemoglobin 40 grams, suddenly it falls down to 6 grams. Somebody has asked whether aplastic anemia can aplastic crisis can occur in GCPD deficiency. I have not read it. I have read it only in thalassemia, sickle cell anemia, and other hemoglobinopathies. But written as chronic hemolysis is not a chronic hemolysis. I have to verify that. I think you can put it in the question box, not here, in White Army. I will take it up, ask the hematologist. So I will also be informed. I will also learn. So please do it. Somebody, please do it. GCPD enzyme function hampers so all these organs. Enzyme function hampers so all these organs. I didn't understand the question. I think put it and elaborate it on, put in the question box to White Army. I will try to answer. I'll read once more and then answer. At present, I don't want to waste time because I don't have immediate answer. So no point in wasting your time. Now come to the next point. After hemolysis, that's the important point. After hemolysis, young RBC is thrown into circulation. They are rich in GCPD. They are rich. Therefore, after hemolysis, you ask for a GCPD level, it will be normal or even supernormal. The younger ones have got a large GCPD. As time passes, it comes down. Therefore, today you have got a hemolysis. Do it after 1 month or 2 months or 3 months. Several weeks, wait for it, then do the test. Otherwise, you will miss a diagnosis of GCPD deficiency. This is very, very important. The reticulocyte will be thrown. They are very much rich, super rich with GCPD. Therefore, don't do the test immediately after hemolysis. Wait for several weeks and then only do it. So it produces classically intravascular hemolysis, hemoglobinemia, hemoglobinuria, hemosideruria. 5 cells in the peripheral sphere. And now these are the drugs that can be implicated. There is no point in remembering them. Books are available, charts are available. Just forget about it. What is the characteristic peripheral smear picture that makes you think of GCPD deficiency? One is bicell, other is hemi-ghost cells. It came in the MCQ, bite cell and hemighost cells. Let us look at it, what it is. Now you find this is the bite cell. This portion has been completely bitten away. That is classical of two conditions. One is alpha thalassemia, which contains beta chain tetramers. Other is GCPD deficiency. If you find an RBC where the one portion is bitten off, which you call it as bite cells, your diagnosis is either GCPD deficiency or alpha thalassemia. Now you go to the next slide. Another finding is what is called a hemighost cell. This is a hemighost cell. You find the hemoglobin is denatured and pushed into the corner. You find this area is white, no hemoglobin at all. Normally the RBC will appear throughout and there will be biconcave nature because that area is not thick. So here you find the whole thing is pushed to one side. This is called one portion, half portion is hemoglobinized, half portion is not hemoglobinized. Therefore, it is called hemighost cell. So there are two findings that tell you that it is likely to be GCPD deficiency. One is the peripheral smear is showing peripheral hemighost cells, or other one is bite cells. So if there are bite cells, also think of alpha thalassemia. Now, what is the bedside test? You will order, which will support the diagnosis of GCPD deficiency. Anybody? I already told you somewhere. Doesn't matter. Hain body test using supravital stain. Wet preparation has to be done. Yeah, in the peripheral, no. In the peripheral smear I have covered. What I intended was denatured hemoglobin precipitates in the RBC because of oxidant stress. You stain with a supravital stain, you can find precipitate of denatured hemoglobin, which is called Hain's body test, which can be identified. You find this is the RBC, hemoglobin is denatured, you are finding it is precipitated here. You can see the bluish spot, the typical of a something like a signet ring. This is the typical of a Hain body test. You use supravital stain, brilliant cell group. This is also indirectly suggestive of a oxidized or denatured hemoglobin by the oxidant stress. Okay, that's what I meant. Now we come to the pyrimidine 5-nucleotide deficiency. The accumulation of pyrimidines in the RBC is perceived to be toxic. It is the only congenital hemolytic anemia where you can identify by peripheral smear. This can be identified, you can get a clue from the peripheral smear that it is pyrimidine 5-nucleotide deficiency. I told you about three enzyme deficiencies, GCPD deficiency, pyruvic acid deficiency, and third one is pyrimidine 5-nucleotide. This is rare, but it brought it because of one finding. The final test for, what is the peripherals abnormality in a patient with pyrimidine 5-nucleotide deficiency? What is this? What does it show? Can anybody identify? Doesn't matter. Correct. Stippling. Basophil stippling. Two people answered, Sambhavi and Chandra. Arunabha Chandra. Both of them answered. Both of them are, I think all of you are interacting very well. Thank you for that. What will the smear show? Basophilic stippling. Lead is a powerful inhibitor of pyrimidine 5-nucleotides. That is why it is happening in lead poisoning. And lead toxicity can generate the same phenotypic finding as congenital pyrimidine 5-nucleotide mutation. They are also same picture. So this enzyme is inhibited in the patient who has got lead poisoning. In the other case, there is a congenital deficiency. Both of them produce basophilic stippling. So we have seen GCSP deficiency. Points to be remembered are more commonly occurs in male because it's X-linked. Spots of hemolysis after that become normal. Do the test only after several weeks. Don't do it immediately. And you can do the enzyme estimation. Indirect clues are antibody and the bite cells and hemigos appearance. This patient is not having it because patient is a female. It did not occur in spec and spurs and absence of characteristic cells. So we have eliminated that possibility. Can GCP deficiency occur in female? Another question you should think about it. Anybody? Somebody has answered? Yes, somebody has answered, but very rare. Any explanation for that? That's what I wanted. Yeah, it is X-linked, but does it occur in female? Male it will occur because there is only one X chromosome. Yeah, correct. A54, that person has answered. Turner syndrome. Yes, mother is a carrier and father is affected. Agreed. So 3 situations. 1, Turner syndrome. Number 2, a carrier female marries a affected male, and the affected male has got the X abnormality, carrier also has got X abnormality. Both of them join together to produce a female, which 2 components of S chromosome which are abnormal, 2 are correct. One more thing. Yeah, XO, agreed. There is something called a Lyon hypothesis, Lyonization. So 3 exception to this rule that males are affected, female can be affected. Only males are affected. Exceptions are Lyon hypothesis, where there is random inactivation of the X chromosome, which can occur, and therefore it expresses. Number 2, Turner syndrome, and a carrier female marrying a male. Therefore, correct. Mosaic pattern also is part of it. You've got general mosaic and focal mosaic pattern. Agreed. That follows lionization. Beautiful. You go to the next slide. So we don't consider any enzymopathies as a cause of hemolysis. They all of them stand ruled out. Now come to the infections. Many infections can produce hemolysis. Typical malaria, babesiosis, Bartonella, Clostridium perfringens. It is toxin mediated septicemia, shock, and hemolysis. Intravascular hemolysis predominantly. Then rarely trypanosomiasis, not a problem here. Visceral leishmaniasis can be a problem here. Am I fast? Am I fast? No, okay. Right. Now we'll come to each. So summarizing the infection, possible infection, malaria, babesiosis, Bartonella, Clostridium perfringens, trypanosomiasis, leishmaniasis. All of them are causes for febrile hemolytic syndrome, which means fever with hemolysis. Now looking at the malaria parasite, you can identify by peripheral smear. Thick and thin smear are required. Histopathologists or the pathologists can definitely identify it. Peripheral smear exam is very important. Diagnosis by peripheral smear examination. And most important point is the Buffy coat examination is very important. Buffy coat examination. Because the parasitous RBCs have got a tendency to get deposited in the Buffy coat when you do the hematocrit. The reason is the density of the parasitous RBCs and WBCs are the same. Therefore, they get deposited in the area where there is a Buffy coat which is rich only in WBC. So their densities are same. So if you take Buffy coat examination, it will give more yield for the malaria parasite. This is a very important test. Acquiline, agreed. Acquiline, agreed. Now, Buffy-Coat exam is important. There is also quantified Buffy-Coat examination where very micro centrifuge tube, blood is filled and centrifuged, and the Buffy-Coat is, that tube is coated with acridine orange. And the malarial parasite will take up this one and emit fluorescence and is examined under fluorescent microscope or ultraviolet microscope. So Buffy-Coat examination, clinically you can do it at the bedside, pathologists will do it. Whereas there is a modification of that where the Buffy-Coat is, the centrifuge is done in a micro centrifuge tube coated with acridine orange, and the WBCs at that level you got the malaria parasite that will take up the acridine orange, will emit fluorescence under ultraviolet microscope. This is a very useful test. You can count the number of fluorescent spots, and also it is said you can identify the type of the species of the malaria parasite. So Buffy-Coat and modified quantified Buffy-Coat examination. Then you have got rapid malaria tests and PCR. These are the usual tests we employ. And thick and thin smear has to be done. And when will you do the peripheral smear? At the peak of the temperature, before the temperature, after the temperature. Correct. Acridine orange, Sambhavi has written. Correct. Chandra has answered before. Why did you say before? Why did you say before? Somebody has written before. All the three are come before, after, and yeah. The correct answer is, suppose the fever is happening at 12 o'clock. You should do it at 10 o'clock or 9 o'clock or 8 o'clock. What happens is the infected RBCs reach a peak, then they lyse. Once they lyse, the fever starts. So when they lyse, they release cytokines and so many chemicals, fever starts. Trigger chills. At that time, if you examine, you will never get a malaria parasite. So what you should do is before. Somebody has answered before. That is the correct answer, which is very often forgotten. You take it at the height of the temperature, you will not get it. After the temperature, also you will not get it. Suppose it at 8 o'clock, 12 o'clock is the fever, 12 noon. You take it at, it would have become mature. The RBC would have been containing mature parasites by about 8 o'clock or so. You take it at 8 o'clock, 9 o'clock, 10 o'clock. That will give more positive tests than when you take at the peak of the temperature. It should not be done. This has been taught by Professor Dr. Balraman Nair. It is more correct than any other answer. Before RBC birds, very good, very good. Before before, agree, fully agree. Others should note it. And suppose you don't have a particular, you got a tertiary fever, cotton fever, you don't know the pattern, in which case you take 6th hourly malaria parasite. Take a smear every 6 hours. 6 o'clock in the morning, 12 o'clock, 6 o'clock, 12 o'clock. Then you will get it. So that should be the thing which you should remember. Then you go to the next slide. Babesia, not a problem here. But it is tick-borne, it can produce febrile hemolytic syndrome. What is the characteristic appearance in the RBC in babesiosis? Anybody? Yeah, Maltese cross appearance. Why Maltese cross appearance? Can you answer that? It has got a tendency to form tetrad. You see, 4 of them are there. 1, 2, 3, 4. They combine together to form the cross. It is the tetrad formation that is responsible. Here also a tetrad is there. Here is a tetrad. And that forms the Maltese cross appearance. Maltese cross. They answered correctly. Now come to the Clostridium perfringens. Infection by Clostridium perfringens, it is a massive life-threatening hemolysis. Massive life-threatening hemolysis. It's a medical emergency. People with clostridial sepsis will die within hours of presentation. Infection can occur in any immunocompromised source following gastrointestinal surgery, genitourinary abscess surgery, pregnancy sometimes, cancer because they are immunocompromised, and diabetes. This will produce febrile hemolytic syndrome. Any site of infection can cause sepsis and fatal hemolysis. Fever, jaundice, intravascular hemolysis will be the triad for Clostridium welchii infection. Now, one classical appearance of a case of Clostridium sepsis infection will be the presence of ghost cell, GHOST. We have seen hemi ghost in GCP deficiency. Here it is a just ghost cell only. Yeah, what is the very good question? What is the cause of hemolysis with Clostridium? It is a toxin. It is something like a it lyses the RBC. It is a toxin, that is an enzyme, some phospholipase or something that will cause damage to the RBC membrane that produces the spherocytes and ultimately lysis. And the same thing explanation holds for the formation of a ghost cell. Here the whole thing is dehemoglobinized, very pale, and this is the ghost of an RBC which was a fully running RBC. Now it has become a ghost with only a very pale cytoplasm. Ghost cell. Hemi goes for GCPD, goes for Clostridium septicemia. And these spherocytes are also common. So you can get spherocyte, you can get ghost cell, and life-threatening intravascular hemolysis. Now, Bartonella is not a problem here, but I will show the slide. Bartonella bacilliformis, human reservoir, it is not common here. I am just skipping it. It is not applicable to our patient. This is the Bartonella. Again, it contains intra-erythrocytic organisms stained. So, how many organisms are there? Every RBC is filled with organisms. This is a picture of a Bartonella infection. Yes, Bartonella, the one species is Bartonella hensley that causes a cascade disease. There are lot of things are there. Agree. Fully agree. Cascade disease is something related to this genus, but species slightly different. Now, Bartonella bacilliform, another one, intraerythrocytic bacillary and coccoid forms. One is coccoid, other is bacillary form. This is like a bacillary, this is a coccoid form. Both forms are present, and that indicates that you are dealing with a febrile hemolytic syndrome due to Bartonella bacilliformis. Now, completion sake, I am telling about trypanosomiasis, not a problem here. So I will just mention it and skip it. Now, one point is antiglobulin, that is important because you discuss a Coombs test. And if you go to Africa and all that, it may be relevant. Direct antiglobulin test positive, but don't be shy of making a diagnosis because international travel, everybody is going to every other country. So somebody will bring a tsetse fly or a mosquito or the organism. Therefore, you may once in a while come across, beware of it, it can happen. Go to the next slide. Visceral leishmaniasis is common in our country, in certain areas, Bihar and other areas. Hypersplenism hemolysis. Usually you find very large spleen. One of the causes for large spleen will be leishmaniasis. Coombs test may be positive. That's what we are in. Just because Coombs is positive, don't think that it is only autoimmune hemolytic anemia. There are antibody mechanisms happening here. Therefore, in a large spleen, long fever, patient turning black, always do a bone marrow to find out LD bodies. Think of this possibility. You may come across once in a lifetime. We have eliminated enzyme defects. Some answer is there. It may be trypanosomia, it may be trypanosomias. Agree that. Fully agree. We have eliminated enzyme defects. We have eliminated membrane defect. We have inclusion body due to malaria, babesiosis, Bartonella infection, all have been eliminated. Now we have seen extra corpuscular factor eliminated in this patient, like fragmentation anemia, autoimmune hemolytic anemia, poisoning, everything has been out. Then we have looked at the corpuscular factors, RBC membrane out, because no peripheral appearance. Enzymopathies out because it's a female, even though 3 exceptions are being given by all of you. Very good. Then we are left with only hemoglobinopathy. And infections we have removed. None of the babesia, none of them were there. Left with hemoglobinopathies. Now we have got hyperproliferative anemia, all corpuscular disorders eliminated, eliminated membrane defects, enzymopathies, hemoglobin disorder, not yet diagnosed. We have not considered hemoglobin problem. Chronic hemolysis with acute crisis. Now the question is relevant. Third day, the patient developed an orbital swelling. Ophthalmology diagnosis of orbital cellulitis. Cause of orbital swelling, I just enumerate. Infection, cellulitis, any swelling there, anywhere, you call it cellulitis. It can be pyogenic infection, it can be TB infection, fungal, particularly mucor, don't forget about it. It can come from the sinuses, mucormycosis. Particularly people who have got a mucormycosis, who are the people who are vulnerable for it? Two answers are there. Yes, iron, very good. Diabetic. Diabetic ketoacidosis will be better answer. Not every diabetic. Diabetic ketoacidosis is a special prediction for that. And iron, that is people who are on iron chelators. And hemochromatosis. Those people are prone for development of mucormycosis. Don't forget about it. Yes, long term, post-COVID. Yes, post-COVID, anything can be involved. Yeah, there are cases where mucor has appeared after COVID. Agree, fully agree. I saw YouTube where the ENT surgeon was talking about several cases of mucor they have seen at that time at the peak of the COVID. Agree, fully agree. So diabetes mellitus, diabetic ketoacidosis particularly. Then you have the iron chelators used in hemochromatosis and hemochromatosis itself. And also in multiple myeloma, it has been described. All people who have got immunocompromised state. These are the important things which I have mentioned. Of course, COVID, well brought out. And your interaction has been very good. All of you. Congrats and thank you for that. And neoplasm secondary lymphoma. You can have a NH lymphoma here. Periorbital swelling, we had a patient about a year back. The first diagnosis made by the two ophthalmologists were lymphoma, clinical diagnosis. So lymphoma can appear, particularly NH lymphoma. Then pseudotumor orbit. Pseudotumor orbit, there is a swelling of the orbit and it gradually starts, patient has a proptosis, and it is related to IgG4. And IgG4 itself can cause bilateral proptosis and endocrine causes. Which endocrine can cause proptosis? I would like to highlight for your examination purpose. Endocrine cause, proptosis. Yeah, hyperthyroid and thyrotoxicosis. A slight difference between, can anybody say what is the difference between thyrotoxicosis and hyperthyroidism? Both of them are same, essentially same, or slight difference can be attributed. Anybody? Sambhavi, Chandra, A54, A54 name, I don't know, I'm sorry for that. Clinical as well as biochemical or pathology wise. Hyperclinical versus toxic features, especially eyesight. No, I tell you, whenever you have got a hyperthyroidism, you should think of thyrotoxicosis also. What is thyrotoxicosis? Yeah, somebody has written not sure. I will try to clarify. So somebody has got a weight loss and all these things. Patient is eating well. You find T4 is high, T3 is high, TSH is low. So biochemical picture is elevated T4 and often elevated T3 and TSH is suppressed. This you can call it as thyrotoxicosis. Now, when you find thyrotoxicosis, is it hyperthyroidism or simply thyrotoxicosis? Suppose somebody is eating a nurse who is beauty conscious, want to slim down, goes on taking 3 tablets of thyroxine per day. What will you find? Weight loss is there, he eating well, and there may be fructose or not. So you do the T4, it will be high, TSH will be suppressed. Now, is it coming from the thyroid gland? It is not. She is taking, this is exogenous thyrotoxicosis. You cannot call it as hyperthyroidism. If you look at the opening sentence in Harrison about thyroid, that is thyrotoxicosis factitia. It is exogenous. Harrison says hyperthyroidism, there is increased uptake, increased synthesis of the hormone and secreting from the normal thyroid tissue in the neck. So it is taking up more, synthesizing more, secreting more. That is hyperthyroidism. In other words, the thyroid gland in the neck is hyperactive. Now, how will you decide whether it is hyperthyroidism or thyrotoxicosis? By any test? By any test. When you find T4 is high, T3 is high, TSH is low, you have to identify whether it is hyperthyroidism. No, not TSH. Not TSH. Somehow it is not TSH. Doesn't matter. I will clarify. I am going to clarify. Now TSH is high, T3 is high. Sorry, T4 is high, T3 may be high, TSH is low. I am repeating. I made a mistake by without my knowing. Even not thyroglobulin. Yeah, thyroid scan. Somebody has written. Chandra, Arnaba Chandra has written correctly. Thyroid scan. What thyroid scan? I-1 31, 29. What does scan use now? Technician 99 says Technician 99 will do. Technician 99 scan is used for this. So I am going back to the answer for everybody. T4 is high, T3 may be high, may not be high. TSH is low. So you are dealing with a patient who got palpitation symptoms. So you have got a thyrotoxicosis picture in the biochemical profile. Now, whether the patient is having a hyperthyroidism, whether the gland in the neck is producing the problem, do the technician scan. Technician scan, it is usually uptake is about 0 to 1. We have seen up to 32%. Some will say it is 1 to 4, whatever it is. They have got a normal value, 1 to 4 or 0 to 4, whatever it is. If it is elevated, 10%, 10, 20, 30, that means the gland is taking up and it is secreting more and synthesizing more, secreting more. So the most important test you should do when you find T4 is high, TSH is low, do the technician scan. That will tell you that it is a hyperthyroidism. So every case of hyperthyroidism will have thyrotoxicosis. But all cases of thyrotoxicosis will not be hyperthyroid. Example, thyrotoxicosis factitia. You take the technician scan, you will find TSH is suppressed, therefore the uptake will be low. So in a patient who has got hyperthyroidism, the neck gland producing more hormone by increasing uptake and then secreting, that patient is having hyperthyroidism. So initially you find that there is a thyrotoxicosis. After that, you narrow down to hyperthyroidism. Once you find it is hyperthyroidism, now you have to decide the cause. It may be Graves' disease, it may be multinodular goiter with toxicity, or adenoma which has turned to be hyperthyroid. That you can also identify by the technician scan. If it is in a Graves' disease, you will find the whole gland in the shape of the thyroid gland itself, butterfly shape, typical. All will be showing excess activity. Uptake will be high. So you can get a picture, computer picture on that. If it is an adenoma, you find a nodule which is hyperfunctioning, which is darker in color. Multinodular, you get multiple chunks of hyperactivity. So for the appearance, first you decide that it is hyperthyroid, then look at the picture. Uniformly functioning hyperthyroid, it is Graves. Also, if it is the localized area, one, it is adenoma, hyperthyroid. Other one is multinodular goiter with hyperthyroid. I think the picture is clear. And if you want, you put a question, I will put the photos sent to Dr. Rao. You can enjoy it and learn. Now, a patient with got a struma ovary, uptake in the neck will be very low. It will be absent. It is not hyperthyroidism. It is somewhere from the other area. If you find in the pelvic area, the uptake will be high, technetium uptake. So conventionally, hyperthyroidism means this neck area is the one that shows increased activity, increased uptake, increased synthesis, and increased secretion. Then you call it as hyperthyroidism. Once you find it is hyperthyroidism, you have to decide whether it is a Graves, multinodular goiter with activity, or adenoma with activity. What is the antibody you do it for? Graves' disease, which is almost always positive. To say Graves' disease is autoimmune. Yes, correct. A54 as answer, TH receptor antibody. So you got uniform uptake, TH receptor antibody is positive, it is Graves. Additional features are clinically uniformly enlarged thyroid, and there may be a bruit. That is the feature of Graves. Are you following? Graves. Now there are three specific features of Graves. Specific three, which will not happen in other hyperthyroidism. It will not happen in multinodular goiter with toxicity. It will not happen with adenoma toxicity. The three are Gravesian ophthalmopathy, otherwise called Gravesian orbitopathy. Number two, it is dermopathy, otherwise called pretibial myxedema. Third specific feature of Graves' disease is thyroid acropathy. I repeat, MCQ question. Graves' disease specific features are Gravesian orbitopathy or ophthalmopathy. Then you have got dermopathy, otherwise called pretibial myxedema. Third one is thyroid acropathy. That patient thyroid acropathy will have clubbing plus periosteal thickening, which will spare the long bones. I repeat, patient will have clubbing. There will be periosteal thickening. Usually it happens in periosteal thickening will happen in bronchogenic carcinoma with paraneoplastic manifestation of clubbing as well as periosteal thickening. There the long bones, radius ulna, tibia fibula are involved. Here the metacarpal metatarsal are classically involved. So three components which tell you that this is only Graves. You need not do the TH receptor antibody. They are Gravesian orbitopathy. Second one, dermopathy or pretibial myxedema. Third one is periosteal thickening, thyroid acropathy. All the three are specific for Graves' disease. Now, how do you identify orbitopathy? Do a CT scan or ultrasound? CT scan will show thickening of the muscles. You have got extraocular muscles will be thickened, sparing the tendon. Extraocular muscles will be bulging, thickened, but the thickening will spare the tendon. If the tendon is thickened, the muscles are thickened, there is proptosis, your diagnosis will be pseudo tumor orbit, which is related to IgG4. Am I confusing you? Am I confusing you? Yeah, fibroblast activated. I just written that I am not confusing you. I hope I am not. Now, so thyrotoxicosis narrowed down to hyperthyroidism based on uptake. Uptake is high, uniform uptake, brewery, uniform enlargement, it degrades. Do the taste receptor test. Look for specific findings. Orbitopathy. Orbitopathy is identified by clinical proptosis, thickening of the muscles, extraocular muscles, sparing the tendon. Proptosis, the extraocular muscle thickened and extraocular muscles thickened as well as the tendon thickened, it is pseudo tumor orbit. IgG related most often. Then dermopathy is specific, then thyroid acropathy is specific, which involve the metacarpal metatarsal bone, not the long bones. There will be clubbing also. Okay, that is about, so something about endocrine causes of this one. One more point is thyroid orbitopathy can precede. I have seen a patient where the patient had unilateral proptosis. Thyroid function was normal. 6 months later, the patient developed bilateral proptosis and thyroid function turned out to be hyperthyroid. Uptake was high. So it can, thyroid orbitopathy, dermopathy can precede, accompany, or follow by months or years of the thyrotoxic or Graves event. That you should know. Now, bleeding into the orbit also can produce proptosis. So we are talking about the orbital swelling. The patient never had, if there is a hemorrhage, there will be bluish discoloration, nothing was there, only some enlargement. So none of the cases are applied to this patient. There is no trauma. So in the background of chronic hemolysis, any other etiology you can think of. So it is not any one of them. Infection, cellulitis, none of them are there. No neoplasm, no pseudotumor cerebri, none of them are there. So in the background of chronic hemolysis, orbital swelling developing, can anybody postulate? Now I am trying to narrow down to lower and lower level. We have eliminated all the possible causes, extracorpuscular, intracorpuscular, all these things. Anybody? Think all of you are bright, you should be able to answer that. Then I'll be very happy. I will give a 5-star for you. Who answers, I will give 5-star. Is that the case which our PG did not answer? So you will try whether you can. Repeats are, I didn't follow that. Repeat. What should I repeat? Chandra, Arunabha Chandra, repeat. What do you want me to repeat? I didn't follow that. So shall I give the answer? Question. Okay. Question is, patient have got a chronic hemolysis. So patient developed a orbital swelling. We have eliminated, there was no finding suggest an infection, even though ophthalmology people said cellulitis. I didn't agree with that. There is no question of neoplasm happening. There is no chance of pseudotumor cerebri, tumor orbit. There are no features of IgG4. There is no endocrine cause. Hyperthyroidism is not there. There is no hemorrhage, no trauma. In this case, in this background, chronic hemolysis, secondary lymphoma mets you can postulate, but there is another beautiful diagnosis. That's what I want you to tell. Mets, and it doesn't matter, even if you feel it doesn't matter, my page, none of the page is made out. So if you can make out, I will give 5 star. I will wait for 30 seconds, just 30 seconds. Chronic hemolysis, any other etiology. Shall I give a clue? Shall I give a clue? Yes. What is the ESR? ESR was 10. In fact, that was the clue. And whatever the abdominal finding, ultrasound, no hepatosplenomegaly. No hepatosplenomegaly. No, it doesn't matter. Doesn't matter. Is it tough for the undergraduate level? Some pages can answer, and none of the pages answered from my side. Shall I answer? Shall I come out bring out the Pandora's box? Yes. Now, can it be vascular? Another clue. Any hemolysis, there can be vascular occlusion. Just consider that, you'll get it. No 5 star. I have given sufficient clue. Maha doesn't present like this. It is a thrilling case. Can I connect a hemolytic anemia with a vascular etiology? Hemolytic anemia comes with a stroke, young stroke. All the books will say that condition. Doesn't matter. Fantastic. Somebody has answered that. Anbaba Chandra. Chandra has answered. Beautiful. Of course, after clues only, but that is good enough. She has answered, she or who it is. The Chandra initial thing I can't read because I don't have the spectacle. She has the person has answered sickle cell. Answer is sickle cell. The 2 tests were ordered. What are they? I ordered sickling test that is positive. So I think good. Somebody has answered with clues, doesn't matter. Somebody read Schilling. Why Schilling test? Sickling test are done. Sickling tests were done. Hemoglobin electrophoresis is done. So diagnosis of sickle cell anemia, chronic hemolysis, hemolytic crisis, and having eliminated. So when you have got an anemia, you should always go in an orderly manner. And I have brought down to kinetic. This is a kinetic approach. Reticulocyte based on reticulocyte production index, hyperproliferative. Then after that, eliminate the cause of hyperproliferative anemia, reached hemolysis. Then corpuscular factors, extracorpuscular were considered one after another. It was removed, and logically we reached a conclusion when the orbital swelling was found. So what will happen is, because sickling will happen in anoxic situations, and you will find sometimes venous occlusion, sometimes arterial occlusion, and they can have stroke, they can have Buchiari syndrome, they can have splenic circulation crisis, and they may come to you with a venous thrombosis. All of them are very common. So I thought of this possibility and asked for sickling cell, and bone pain need not be there. Acute chest pain need not be there. Need not be there. But this patient only 18, maybe some 30 years, she will develop that. Now, all need not be there. And they also have urinary abnormality called isostenuria. What is isostenuria? Isostenuria, ISOSTHENURA, isostenuria. Fixed specific gravity. Because the persistent damage to the kidney, tubular dysfunction occurs. Yeah, fixed. Somebody has answered correctly. A54, that person has answered. Fixed specific gravities will happen in, that is classically we are taught in physiology. This one. So ultimately diagnosis. Now, how do you reach a diagnosis? Step by step. May have predisposed to capsulated organism infection causing orbital cellulitis. That is also possible. You have to think about it. But there is no fever, there is nothing. and there is no pneumonia, some staging should be there. But this will very well explain, which prompted me to think of the sickle cell, and the diagnosis turned out to be sickle cell, and we treated appropriate blood transfusion, patient improved, and that is the condition. No, she never had recurrent ulcers. Maybe she will develop later. Recurrent ulcer also is one of the common things in a chronic hemolysis. Now, we are reached a conclusion. This is a stepwise fashion in which Sherlock Holmes goes. We should do all of the clinicians should do it. And this I have added a slide. The slide will be sent to you. I taken from one of the hematology books. One more slide is there. This is also very useful, how to analyze hemolytic anemia. I am not spending time on this because already late. This also another slide. Somebody the other day asked about a difference between anemia. I don't know who asked. Anemia chronic disease versus iron-deficiency anemia. With that, I will stop because already getting late. You will be tired. Hope you are not bored. You are not exhausted. Okay. Yeah. Thank you for that. Now, anemia chronic disease. Some of the features I will just tell them. With that, I will close the class. Still energy. Okay. Agree. Fully agree. Because tomorrow morning I have to get up at 4 o'clock and go to the hospital. That is the problem. Otherwise, I would have continued. Okay. That day I was sick. I was falling for having upper respiratory infection, having fever for 2 weeks. That's why it took such a gap. Anyway, without wasting time, the ACD versus IDA. And here you have got ACD. MCV will be normal or decrease. Same here IDA. Then serum iron concentration, anemia chronic disease, reduced or normal. And even anemia always reduced. Always reduced. Thank you so much. Total bending capacity, reduced or abnormal or normal. It is increased. IDA, it is increased. Now, the next point is serum transferrin. It is reduced or normal. It is increased. So total bending capacity will be increased. IDA, it will be the serum iron will be reduced, and serum transferrin concentration will be increased. Now you have got transferrin saturation. So what are the points? I will recap. Serum iron is reduced, obviously, and deficiency. Total bending capacity is compensatorily increased. Transferrin concentration increased. Transferrin saturation will be reduced. Because iron is reduced, transferrin is increased. So naturally, there will be marked reduction, usually below 16% in patient with iron-deficiency anemia. On the other hand, in a patient with ACD, serum iron can be reduced or normal. Total bending capacity reduced or normal. Saturation reduced or normal. Saturation percentage normal or reduced. These are so some difference. There's always reduction in the percentage saturation. Transferrin saturation can be normal. Sometimes it reduces. Serum ferritin, normal or increased because it acute phase reactant. Serum ferritin is always reducing IDA. Again, you have to remember it is an acute phase reactant, it can be normal, even though here it is written as reduced. Classically, if it is reduced, it has to be iron-deficiency anemia. Normal is less than 10 nanogram per ml or 10 microgram per liter. There is one more thing which you should know. Harrison has given that what is called a free soluble transferrin receptor. So you find what happens to transferrin? Transferrin will be increased in iron deficiency. So the transferrin receptors will be shed into the plasma. From the plasma, you can estimate the transferrin receptor concentration per unit volume of plasma. So that is called a free soluble transferrin receptor. That is always normal in anemia of chronic. This is an important finding. I don't know who asked that person. The answer is given for that person. Soluble transferrin receptor is normal in ACD, whereas soluble transferrin receptors is increased in iron deficiency anemia. Therefore, one more combination, the soluble transferrin receptor divided by logarithm of the ferritin. So soluble transferrin receptor increase in Anemia anemia and ferritin will be decreased. Therefore, if you take the ratio of free soluble transferrin receptor divided by logarithm of ferritin in Anemia anemia, you will find it will be markedly high, more than 4. Whereas it will be low in less than 1 in anemia chronic disease. So the last 3 things are important. Ferritin, if it is reduced less than 10 nanogram per ml, is always iron deficiency. But it can be normal even in iron deficiency anemia because it is acute phase reactant. Soluble transferrin receptor is very important. It's not usually done only in certain hematology labs. It is done. It is normal always in ACD, whereas it is increased in IDA. So taking transferrin receptor and ferritin, you take a ratio, make a ratio, free soluble transferrin receptor divided by logarithm ferritin, log of ferritin, not the ferritin value, take its log. You find ferritin, what will happen? It will decrease. In iron deficiency anemia, transferrin receptor will increase. So you get a very high value in IDA. So ratio of transferrin receptor divided by logarithm of ferritin will be quite high, more than 4 in iron deficiency anemia and less than 1 in anemia of chronic disorder. This came up in journals. I discussed with even hematologists. They said they are not routinely doing it. But for MCQ, you can learn about it. Soluble transferrin receptor is given in Harrison. So you should know about this. Is the thing for difference between ACD and IDA. And the 3 more charts I have given. I think we come to the almost end of it. Thank you so much. Hope you are not much tired about this because it's too long a time for you. Still, if you are able to concentrate, well and good. Thank you so much for the cooperation. Thank you, thank you, thank you. Any questions or any suggestion? This I will be sharing with Dr. Kishan Rao shortly. I will send him by the email and he will share with you. I think it was sufficient enough. Got lot of points, I believe. Hopefully, it is useful. Thank you so much. Thank you for the opportunity. Dr. Kishan Rao, I don't think he's here. I thank him. I thank White Army for the wonderful opportunity. And also, I thank the students for very much interactive. All the time they were interactive, but today it was exemplarily interactive. And I also congratulate the person who has made a diagnosis of sickle cell. Even it doesn't matter after Qs, but made it. That is excellent. Special mention for 3 cardinals. Yeah, that is very, very important. Also, 2 more points I will just add. You can have lymphadenopathy splenomegaly increase because it's immunological. They are not very specific. 3 specific I already told you. Non-specific things are generalized lymphadenopathy you can have. You need not be surprised. Splenomegaly you can have. You need not be surprised. Thank you. Shall we stop?